I do have a very good example of a situation which did arise just recently. We were referred a patient to come to our inpatient palliative care unit, and this patient was in a private hospital, and it was a young woman who had had two, unfortunately, had two significant strokes over a 7-year period, and the first stroke had left her quite disabled. But she had made significant recovery and was leading a very productive life. And in that time, she had said very clearly, and had to family, and although hadn't necessarily documented it, but it had written down in a less formal way and communicated if things happened again like this, that she didn't want to be kept alive in a situation where she wasn't able to recover. And in fact, then she did subsequently have another stroke, and this is 7 years later. And so she was left with this very, very disabled state where neurologists and people decided there wasn't most probably going to be a huge amount of recovery. So part of that process was that she was already being fed through a PEG feeding tube. And initially, the clinician who was looking after her, the physician, was finding it very, very difficult to understand that the family started talking about withdrawal of PEG feeding. And so this was a clinician that, even though he appreciated that this person was in dire straits, he felt that at the moment that they needed to persevere. From his perspective, they needed a longer time, that even with recovery, the use of a feeding tube wasn't necessarily seen as something that he could actively withdraw. So not so much taking the tube out, but was stopping the food going in. He felt that that wasn't something that he could offer in their particular hospital. And so this caused a huge amount of distress, not only for the clinician who was trying to do the best by the patient, but understanding that these discussions had occurred and that there had been quite significant connection with the family who had medical power of attorney. So it was a real misunderstanding of really what the context was. And instead of trying to focus on the legal aspects of what is a medical treatment, what isn't, and so forth, the conversation needed to come together as this, what is the best care for this person at this time. In this situation, when this person's expressed very clearly what she would see for herself as an important part of her living and then dying, which had been communicated to the family. And so bringing the clinician then to a point of understanding that it wasn't about him not offering what he felt was the most appropriate care, it was trying to have a shared understanding. And so that was our role, was to bring them to a point where we focused on the clinical and we focused on the patient and the context, not on the kind of moving it beyond that into a more escalated. And it was quite powerful to see the senior doctor, who maybe hadn't considered these before, understand and walk into that situation more happier that we had walked into this space and found a situation that had a solution. Another patient was referred to us, a youngish guy who has had a lot of health issues, and which eventuated, I think, maybe in his 20s, having a heart transplant. And he's a sort of gentleman who's had a very kind of full life. He's busy, works, all those sorts of things, but started to have some rejection issues to do with his heart transplant and so forth. And he started to become chronically unwell, so 30s, early 30s. And what wasn't apparent when we first started meeting this gentleman, but it soon became apparent, was that his decision-making capacity was quite limited, and that many, many years ago his parents had to take some responsibility for his decision-making. And so because he presents to the world this sort of tall, lanky, kind of busy sort of guy who possibly, who everyone sort of connects to, had a pretty sort of engaging personality. But once you actually got to know him, he found it very difficult to move beyond just just sort of immediate concepts, and you couldn't really focus on longitudinal things and planning and so forth. And in fact, for somebody who was in his 30s, he most really had a sort of, late childhood sort of way of thinking in the world. And because of that, his parents now took responsibility for a lot of the decision making, but that put a huge burden on them because it was a very burdensome issue, and trying to make those decisions. And he had been so unwell that everyone was focusing on his end-of-life care, and the appropriate decisions were being made and so forth, which is why he came to us at the palliative care unit. But once we started to focus on his good symptom control, and we managed to stabilise things, which hadn't been apparent at his other hospital, we started to focus on reshaping the goals. And even though the parents, the power of attorney, had been helping to make those decisions around end-of-life care, we certainly had to start those conversations around saying we actually think the goals are changing, and that we think he's going to improve, and that we can focus on him getting out of hospital. And so the ship's quietly steered around, and we managed to then work through the medical problems, and the family had to then refocus on what was best. We weren't escalating care, we were just providing appropriate care. And so he was actually discharged from our palliative care unit. He went back to work. He came back in about 4 or 5 months later. We settled him again. He went back out again. He's still living. About 2 years later, leading a productive life. He's reconnected with the heart people at one of the hospitals, and interestingly, so sometimes when the focus is one thing, you have to start moving, even within an advanced care plan, you have to start moving around those goals if things start to shift and change. And you think the best for this person is that actually they're not dying, that they're still living, and there are things that can be done. Now that may have changed at any point, but at the moment he's now stabilised, and it must be at least, I think, 18 months down the track since we first met him. But it's been a very interesting process even for us, and challenging for everybody. Another example of where I think advanced care planning, even in the face of focusing on dying and death, is a very active process. It's not a passive, and it's not a one document or a one decision fits all. A lady who had been about late 50s, early 60s, and quite a social activist. She loved getting on the computer and sending off letters which was great. We love, you can have great dialogues about issues and social justice and things. Anyway, she had had treatment for a particular cancer, and the radiotherapy that she had been curative of her cancer had left her with significant lung disease, and so significant that it got to a point where they felt that there was no longer any escalation or active management for her lung problems, that all we could do was treat her chest infections, but it got to a point where they felt that any further treatment she may die, she may not. So it got to a point where the patient themselves recognised that she was dying from this basically iatrogenic lung problem. She decided very clearly that she no longer wanted any more antibiotics, that next time she got a chest infection that she should be allowed to die naturally. Well, so she came to us, which appropriately, where everyone thought the next time she gets sick she's going to die, so she came to our inpatient palliative care unit. And of course, as things can happen, it could have focused on dying, and she was very much focused, but she'd convinced herself that she was in that dying time. But the next infection didn't kind of come. And even though she was on high flow oxygen, 10 litres, and we got about 8 to 10 litres a minute, which is high flow, it didn't come. And so her whole world was focused on dying. She wouldn't leave the room. She had lots of visitors engaging. She did a lot of finishing off. She talked about her advanced care planning, but she'd never written anything down. She had a medical power of attorney, but it was very much focused on everything I'm doing is focusing on dying. But then the infection didn't come. We started getting the oxygen down a little bit. She just didn't think her goals were going to be anything but dying, so she wouldn't kind of move out the room. And we started to, again, work on that space where she started to understand. And one day she said to us, I think I know where you guys are coming from now. I think my goal, she actually said, I think my goals are changing. And she started to say, I think I'm ready to look outside the room. That was the way she said to us. And this is after about a month and a half. So you can imagine we've all been kind of barracking in the background saying she's got, and because we were trying to get her to see there could be another place to be. We weren't doing anything, that was the thing. We weren't actually, and finally she actually realised there was something more, and she said, no, I think I do want my next chest infection treated now. I think I'm enjoying my social kind of activism, and I'm enjoying, so it was a very moving time to see this person over a number of weeks shift in that space, and shift so much that we were able to actually get her out of the room, actually get her walking again, very short distances over another month or so, focusing on the world again, and she was quite productive for the next couple of months. But the whole focus changed. She said, and so next time she did get a chest infection, which was this is 3 months now, we did start to treat it, but she very clearly said, I do want IV antibiotics, and we agreed, we thought because her goals had focused out, we'll give those antibiotics. But if we don't get anywhere in the next day or so, she was very clear, she said, then you can focus on my dying again. And so we didn't know. We were already making plans for her to go to residential aged care. We'd teed up her to go there, the oxygen requirements were sorted out, the family were happy, we'd made the plans. But then again, this infection came, and she did significantly deteriorate after 24 hours of IV antibiotics. And so we then kind of respected the refocus again that we had had. And this had been a conversation all along. She had appointed a medical power of attorney, but she was very much aware of her situation right up until the last few hours. So again, a very good example of how it's a very active process. These remind me of the need, why it is all about hearing from the patient and the family and communicating kind of the medical context, and kind of it is an ongoing process for a lot of people. And another example for this is the same day we had 2 people transferred from residential aged care into our emergency department. Both had fallen over, both had fractured their necks of femur. 2 different family situations. One family situation had discussions when they went into the residential aged care. There was an advanced care plan, but this was all around her loss of cognitive function. She was leading a pretty good life. She was still cognitively impaired with early dementia, but reasonable life. New problem, fell over, fractured, new problem that needed to be sorted through. And so very much from the family's perspective, they wanted to respect her advanced care plan, but it was around dementia, it wasn't about the fracture, and they really wanted to stabilise her pain if possible. They found she had a chest infection. They said, look, let's treat the infection because that's caused her to fall and fracture her hip. Let's see how she goes over a couple of days. And then we can see whether the hip needs fixing if she starts to recover. The other person, exactly the same scenario, wasn't so clear about the family and the connection to advanced care plan. Again, similar scenario, what do we do? And so in that situation, they did offer to escalate care in the sense of giving antibiotics initially because they felt that was the best medical care for that person. It was a new problem again, much more advanced dementia, but again, it wasn't all about the dementia, it was all about the fact she got this new problem with pneumonia. So, but interestingly, the scenario was a lot more stressful for the family where they didn't have the discussion and the care plan versus the one that had the discussion and care plan. Both got antibiotics for a couple of days. One of them started to recover, and the other one started to deteriorate, and the one that deteriorated, they stopped the antibiotics and allowed her in our unit to have a peaceful and kind of natural death with family, but bringing this is the more distressed family, and then the other family, it looked like she was stabilising, but then she deteriorated as well and was allowed to obviously to die peacefully So the outcomes are all the same, but this very distressed family on one side and a very empowered family on the other side, who felt the process had been great. The healthcare facility had responded to the new problem appropriately, but with limitations if things didn't go the way they expected. And it was just very empowering, because then in the bereavement phase, one of the families still had quite a bit of kind of distress, and that was the one where there hadn't been this sort of preemptive discussions, and then one where they felt, no, this was the sort of experience their mum would have anticipated and expected. So that was certainly a scenario that we sat with one day, where the two patients died of us 3 or 4 days later after coming into emergency. So.